And I chose a topic which is very simple, managing cancer patients in suburban Bangladesh, an audacious fantasy or sheer necessity. So in the few next slides, I'll be going through some of my stories, and thereby I will try to have an answer whether treating cancer patient is really a challenge to us or it's just a fantasy. So as I was talking about, I'm a surgeon working at an Upazila health complex as a consultant of surgery. I don't have any conflict of interest. So with an admissible existence of poor health consciousness, low socioeconomic status, lack of education, inadequate infrastructure, and limited interdisciplinary collaboration, managing cancer patients presents a daunting task for physicians and surgeons of Bangladesh. The rising prevalence of cancer globally demands urgent attention and necessitates addressing the existing challenges in cancer care. This article depicts the experience of a young general surgeon managing cancer patients in northern part of Bangladesh and highlighting 5 of his observations. I am a surgeon. Mostly I do open surgeries, and these days very often I also do some minimal invasive surgeries, and I feel proud of it. I serve at a very limited facilities, but yet there are a lot of stories of ours to tell in the world, and Bangladesh has got a lot of success stories in health sector. Lancet claimed Bangladesh success as a mystery to the global health. And if you look at the health structure, this is very much exemplary structure. It's starting from at the root, the community health clinic, and on the other hand, we see that these are the giant institutions nowadays serving this country. And we have very much success stories. We gained a vaccine award, we have got UN award for MDG accomplishment, our family planning, child nutrition, and also the recent COVID-19 management has got a lot of praise throughout the world. But whenever it comes to cancer care, we often struggle. So let's begin with some of my stories. The first story is I named it the disinformation trap. So a 17-year-old male presented with large soft tissue swelling of the leg. The caregiver denied any prior medical treatment, but medical documents later revealed that the patient had been diagnosed with sarcoma and received 1 dose of chemotherapy before he came to my chamber. The patient and his caregiver repeatedly said they are very poor, they came from a very remote village, they don't know anything about this, they are helpless, they want to be treated by me. But then on the very day of the surgery, I came to know the patient has already received chemotherapy and some other management in tertiary level hospitals. So I got an observation, the culture of distrust, social fear, and taboo strongly exists in our practices. And it's time to talk and promote more on cancers to the community. So second story is all about decision dilemma. This 55-year-old man with low rectal cancer faced contrasting opinions from various consultants regarding the treatment approach. Actually, he visited 3 surgeons, 2 of them were colorectal surgeons, and 2 oncologists. One of them were radiation oncologists and another one medical oncologists. And they gave contrast opinion. Someone said, okay, go for surgery first, and the other one said, okay, go for the radiation and then come back for surgery. And this patient, being from a very educated background, he was very much in dilemma, and later thought of getting abroad for a specific decision. So the observation 2, lack of empathy and poor communication often fails to gain the trust of the sufferer, resulting in draining of patients to other countries. The third story I named is conscious ignorance. This 75-year-old man came to me with the diagnosis of gallbladder mass. It was a locally advanced case. He was initially consulted by a gastroenterologist who said, nothing can be done. Okay, your job for the world is okay. It's terminated, so he advised for some palliative management. But later when he came to me, I evaluated the radiology and we see that this is a resectable cancer. So we went for a radical cholecystectomy with a Roux-en-Y hepaticojejunostomy. And later, it's 2 months after the surgery, and patient is still surviving with a good quality of life. So observation 3, lack of interspecialty collaboration and communication regarding the available services accentuating patient suffering. And number 4, this might be a bit, let us talk on this. This is called intellectual misadventure. This patient, 27-year-old female, was clinically diagnosed with breast abscess by a specialist gynecologist and underwent inappropriate surgical procedures, but later found to have infiltrating ductal carcinoma of the breast. The patient had received an improper incision, improper management, and when he eventually came to me, we see that we can do very less for her. So the observation 4 was professional negligence, misconduct, and misadventures are still strongly evident in clinical practices, often costing the patients in terms of morbidity and mortality. And the 5th story of my presentation today, we named it enthusiastic inefficiencies. So very often we see that people are getting degrees, maybe a certificate course or diploma or a master's course, and they jump over to clinical practices, and there we see that very often in their reports, in their performance, we see it is not what actually we want from them or what actually it should be. So this young male underwent an abdominoperineal excision of rectum for low rectal growth, depicting high-grade dysplasia on repeated colonoscopic biopsies at a private clinic. But histopathology reports showed poorly differentiated mucinous adenocarcinoma, indicating a diagnostic discrepancy. So this is not applicable only for a young colonoscopist or endoscopist. This we can see for also in sonologists, even also for the clinician like us young surgeons. So observation 5 is, attaining clinical expertise and excellence is a stepwise journey and not just about carelessly jumping over. So to sum up with my 5 observations, observation 1, the culture of distrust, social fear, and taboo are strongly exist in our practices, and it's time to talk and promote more on cancers to the community. Observation 2, lack of empathy and poor communication often fails to gain the trust of the sufferer, resulting in draining of patients to other countries. Observation 3, lack of interspecialties communication and collaboration regarding available services accentuating patient sufferings. Observation 4, professional negligence, misconduct, and misadventures are still strongly evident in clinical practice, often costing the patients in terms of morbidity and mortality. And the last observation, attaining clinical expertise or excellence is a stepwise journey and not just about carelessly jumping over. So as I was mentioning, the question I put, whether this is an audacious fantasy or sheer necessity to serve the cancer patient in suburban Bangladesh. So my answer is, increased cancer burden is an undeniable reality, and attempting cancer treatments with limited facilities, well, maybe it's an audacity, but these audacity drive us to go more, go further, and achieve our goals. So, okay, to some level of audacity is good. And addressing cancer patients at whatever facilities available is a proven necessity at this point of Bangladesh. So, as we were dreaming for a smart Bangladesh in 2041, I guess our collective effort will help us to uphold the flag. Thank you very much.